Welcome to episode 256, Detecting Dropout Danger, Data-Driven Ways to Keep Clients Engaged and Reaching Goals, featuring Keith Klostermann, licensed marriage and family therapist and mental health counselor. Make sure to subscribe to be alerted about future episodes. By Clearly Clinical, learn, grow, shine. Hi, everybody. Before we dive in, I want to make a quick note about this episode. You might notice that my audio sounds a little clicky. I realized afterward that my microphone needed replacing. We're so sorry about the sound quality on my end, but the conversation with Dr. Klostermann was too valuable not to share. Thank you so much for your understanding and support. We are not audio engineers, we're therapists, and we really appreciate you listening in. Hello to our listeners. My name is Elizabeth Irias, and I am so happy to have Dr. Keith Klostermann here with me today. Keith had joined us a while back for a conversation about some of the ethics around working with intimate partner violence and dispelling some of the myths. And I'm so happy to have Dr. Klostermann back today to talk about a topic that is like super nerdy and awesome in my heart, which is measurement-based care. And I know not that many people get excited about measurement-based care, but I think that both Keith and I have the goal that by the end of this conversation, you actually might get a little excited about it. Thank you so much for joining us today, Dr. Klostermann. It's delightful to have you.
Well, I'm glad to be back. And I agree. You can't have this conversation with everyone. There's a select few, right, that where you can really nerd out on it. So I'm glad to be here.
We're totally going to nerd out and you all get to listen in. Keith, for our listeners who are not familiar with your work, why don't you take a minute, please, and tell us about yourself?
Sure. So I am a quality assurance manager at the Cohen Veterans Network, which is a national group where we partner with clinics across the country to provide evidence-based targeted treatment to veterans and their families. So one of the big things that we find is that demand is so great right now. So we really pay attention to getting veterans and their families into treatment in a timely way, but then also providing evidence-based services and tracking that and helping the clinics to do that. So my role is I help the clinics in terms of their data analysis, in terms of what does access look like at the clinic, and then what does demand look like as well. So I help them sort of translate that into clinical practice, really paying attention to, well, why does this matter? Why should we care? And so on. I also work at Walden University. I teach in the clinical mental health counseling program, and primarily I teach the couple and family courses. I have taught the research classes as well. I really love working with students. You know, I've been training therapists for probably over 25 years in terms of, and at various stages of their career development. So taught for a long time. I also do trainings, have led trainings across the US and in the UK. Mostly on couples therapy for substance use disorders, but it's something I'm really passionate about. So I really like working with clinicians, helping them to sort of reflect on what they do and why they do it, and then share some of the things that I've learned. And I would say both good and bad. You know, some of the greatest learnings that I've had have come from my mistakes. So always happy to pass along the things that I've learned along the way.
Awesome. Thank you. I would love to hear your relationship to measurement-based care. Like of any topic that you could come back and talk with us about. Why is this the one that you were like, oh, we need to have a call?
So this is a great question. And it really started during my doctoral program. So I had a supervisor that was really interested in client perceptions of therapy, what they were experiencing, and was really in tune with the outcome literature at the time. He really focused on what does the outcome literature say about what works in therapy? And as a result of that, usually what we find is that there's some measure of the alliance, right? And in particular, the client's perception of the alliance. So he went on to sort of, his thing with me was always, how do we know when therapy is working beyond what we think, right? Because there was all kinds of literature at the time that said that therapists tend to be poor predictors of outcome, right? And really understanding what's happening in a session. So, for example, we would look at these studies where we would look at the therapist's rating of the session versus the client, and oftentimes they were really different, and it cut both ways, right? And I think a lot of therapists can relate to this in the sense of sometimes you work with a client and you walk out of the session and you feel like, oh my God, I have no idea what we just did in there. I don't even know if this is working. And then you ask the client, and the client says, well, yeah, this is really helpful. Even though for us, we don't really understand what's working or why it's working. Conversely, we've probably all had sessions where we thought, yeah, I really nailed this. This is going really well. And then we don't see our clients again. They just disappear, And to drill down even further, when we look at the outcome literature in terms of most frequent number of sessions attended, the modal number is typically 1, right? And I think there's a reason for that. I think that a lot of clients come into therapy sort of looking at, they have an idea of what it is they're looking for, but as therapists, we don't sort of tailor the intervention to meet their preferences, or it's not what they want. And they don't tell us, right? They schedule another appointment, or, they just no-show, or they call and cancel. And we don't understand why. So I think in my training, this was something that we really paid attention to. And we were using, so Scott Miller, who's out of the International Center for Clinical Excellence, has done tons of work in this area over the last probably 20 to 30 years. And Scott Miller had developed what he called the outcome rating scale and the session rating scale. And they're two really brief and simple measures. I think they're 4 or 5 items each. One measures outcome, and the other is a measure of alliance. And we would use those at every session. So my mentor sort of taught me how to introduce those, taught me the value of why the data mattered beyond just sort of doing it, really translated into the clinical utility of it. Like, hey, this helps me better understand what's happening in session and what my clients are experiencing. And then also the other piece to this is, how do you have conversations about the results of the measures, right? Because you don't want to just give a measure and then clients, they sort of think, well, why am I doing this? So I think part of it was, how do we integrate this into the overall treatment plan?
Awesome.
Does that make sense? Yeah.
I mean, to me, it does. And I hope it does for our listeners. To drive home some of the things that Dr. Klostermann is talking about today, I also want to throw out there, we've had a number of conversations with Dr. Scott Miller. We also have one episode on the podcast with Dr. Daryl Chow. And there's also one that I did, in the wee early days of Clearly Clinical, talking about the importance of measurement-based care. And I'm excited for the conversation today because I think it's looking at it really from a best practices perspective. And these are the most unsexy, unfun words, to say clinical utility and best practice. This is not something that most people start drooling over. But it is so foundational. And I think many of us never learned it. We learn about diagnosing and maybe 8 minutes about coding, and probably very little conversation about why we're doing what we're doing. And then you fast forward to being a provider with some third-party payer, whether it's state funding or insurance or whatever it is, and they're saying, we need you to fill out all this information and give us a treatment plan and yada, yada. And it's been my experience that most clinicians have no idea why that is, other than the bureaucracy at work. And it turns out that it actually could make us better clinicians. And that's where I'm just going to kind of hand the mic back to you on this one, Keith. But it is, all these pieces fit together. And I think for many of us, I know even for myself, it was only when someone explained how all the pieces fit together that I went, oh my gosh, and had this epiphany where it's whoa, so I could keep going to all of these trainings and spending all this money and getting all of these acronyms after my name, or I could actually look kind of at the nuts and bolts of why therapy works, when does it not work, and then kind of shift the whole paradigm. So take it from there, Keith.
I love that. And so Scott Miller and Daryl Chow, I just put a plug in. They have excellent blogs, and Daryl has a newsletter that he sends out. It feels I think it's weekly, but it's awesome, and he does such a wonderful job of translating the research piece of it to clinical practice. Right, sort of distilling what are the central elements of this, sort of what you were referring to, the why. Why should I care about this, right? I'm a clinician, I'm not a researcher. He does a great job of sort of saying, here's what we found, or here's what they found, and this is why it matters. And here's what you might consider in your sessions. So it's not real preachy in the sense of you have to do it this way, but it's why not try something different? And I think they're both wonderful resources. So for the listeners out there, if you're interested or curious about this topic, those are great places to start. Just signing up for the blog and seeing, What is it that they're talking about? How do they distill this? What does this mean for my clinical practice? I think it's so important. And I think what I would add, Beth, is you mentioned something really important about, well, we have to do this, the bureaucracy of sometimes doing mental health treatment. And I think for a lot of funders and even grants, right? A lot of agencies now have grant money that they have to demonstrate to the funder, right? Like the results. And that's part of it too sometimes. So we have all these administrative pieces of this. But I think, you mentioned the training piece. I've thought this for a long time. We don't really train therapists during graduate school in terms of how to do this, right? We sort of learn the machinery of therapy and how to sit with somebody and diagnosing and questioning and things like that. But we don't really teach people how to incorporate measures or assessments into treatment. And I think that's something that when we think about where do we go from here, that's a piece of it. I think that our training needs to incorporate that in because it is an essential part of what we do.
In the conversation I had with Dr. Daryl Chow, that was one of the things we were talking about, the complexity of being a clinician and holding an iPad or sitting at your desk, or you have this big stack of paper that you have to fill out with a client in the very first session. And yet there's this imperative piece of establishing some sense of rapport, some kind of safety and care. And like, how do you do that? And particularly for a new clinician,
yes. Oh my gosh.
Good luck.
Yes.
Good luck.
Well, yes, it's overwhelming, right? And I always say, I tell students this all the time, becoming a therapist really it's a developmental process, right? It's akin to when we learn to ride a bike. When you first learn to ride a bike, there's usually somebody who's behind you, maybe holding onto the back of the seat, steadying you, right? You're hyper vigilant about where your hands are on the handlebars, where your feet are on the pedals. Somebody's sort of with you along the way. But typically what happens is very soon after that, you hop on your bike. You're not thinking about where are my hands on the handlebars, where my feet are on the pedals and whatnot. You're just sort of thinking about, well, where am I going, right? And I think that's what happens with us as therapists. As we learn to quiet all the things we think we're supposed to say and really be present and to really listen, some of these questions begin to organically emerge. But I think that there's a process to that. It doesn't happen overnight. And we all went through it. Right? I'm sure you can remember some of your first sessions, right? Where it was like, oh my God, what am I doing here? I have to ask this question next, right? Rather than allowing it to come to us and getting out of our own way. So I do think that because it is so complicated in becoming a therapist, having some skill, having some training where people can learn to use measures and to have types of conversations around the use of measures in their training would be a really safe way to do it. When we wait until people are already practicing, I think it feels burdensome. And then sometimes I think that there's a fear of there being an evaluative component to it, where who's going to look at these results? Am I going to get in trouble for this, right? What if, therapists, we want all of our sessions to be a home run, right? A slam dunk. We know that that's not always the case. And I think sometimes we worry about what the results say about us as therapists and what a supervisor could do with that who's not really tuned into this process and why we're doing it.
Yeah, and I'm actually really glad you brought up that point. I remember having that conversation with Dr. Scott Miller, and the dangers of misinterpreting measures and the way that they potentially could be used in a punitive manner. And I've seen it, like having worked with facilities, and it is really kind of completely counter to the spirit of FIT, particularly of feedback informed treatment, but really the entire spirit of measurement based care. And just to clarify, both Dr. Klostermann and I are very familiar and trained in feedback informed treatment, which is one variety of measurement based care, but we're really looking at the whole practice today, not just FIT. That's just kind of one little pocket of it. That's a basis for the research from delivery practice that informed feedback informed treatment was really, I think, the birthplace of measurement-based care. But now there are all different kinds of measures. But the difficulty is when it's used in systems in a way that was counter to how it was intended. It's intended to improve care, not to be punitive or punishing for the clinicians that don't have the highest scores. Can you expand on that, Keith?
Yeah, absolutely. So I think this is a super, super important point. At least in my experience, I've seen clinicians that are sort of a one-person show, which is, hey, I want to start using measures. I'm interested in this. But they don't have the support, let's say, or there's not an understanding within the clinic of why you're doing it and what it's being used for. I think that to implement, one of the biggest challenges with measurement-based care has been implementation, right? Sustainable implementation. We all know what it's like to go to a training and we learn a new thing and then we come back and we're the champion,
so
right?
excited.
Oh yeah, so excited. We're the champion, but then we're trying to bring other people along with us. And maybe leadership is kind of like, well, yeah, she's the person that's responsible for this, but she'll take care of it. And then what happens is that person either gets burned out, or when that person leaves, that particular aspect of the program leaves with that person, right? So some of this really is like, I think measurement-based care has to be integrated at all levels of an organization. So that's from the senior leadership to the clinicians, to the front desk staff. I think everybody has to understand, why are we doing this, right? What's the purpose of doing this? How is the information being used? I think it's critical, if you're going to have a sustainable program, that everybody is on the same page, that there's an understanding and a transparency about what we're doing and why we're doing it. From the individual clinician standpoint, I think, the measures are important in the sense it's another piece of information. It helps us understand what's happening, what the client's experience is, that can then be part of our conversations, right? There's no, the measures themselves aren't a panacea. There's nothing that they're going to do other than sort of help us to make sure that we're on track, that we're understanding what the client needs. And I think this is a really important part. It sort of helps us understand when therapy isn't working, when the client isn't making progress. It opens the door for us to have conversations about, what do we need to do different, right? Is this the most appropriate form of treatment for you? Should we try something else? And to have a collaborative conversation with the client about what this means. It's one data point, because I think sometimes therapists worry that, well, now the data is everything. All we care about is the data. That's not it. It's one piece of information among all the conversations that you're having with clients about what's happening in the room in front of you. So I think it helps us better understand whether or not we're on track. And when we're not, it helps us also to understand what to do different.
I want to share my first experience with measurement-based care, and then I would love for you to talk about it, because I think my experience is probably a very, very common one. It was my first associateship, and I had been working as a therapist while I was in school, to do those hours during my education. But once I graduated and got a real job, and I remember they handed me the stack of intake paperwork and they said, okay, we're working with adolescents here. And so they need to fill out these 2 measurements while you're with them in that first session. And, if the person has difficulty with this language, we can get you these measures in another language, or if it's easier, you can read them to them and they can, indicate to you what their answers are. And so I had these metrics and I spent 15, 20 minutes with the client doing them. And then I turned them in and then I never saw them again. And then 90 days later, they said, okay, per our contract with California Probation Department or whatever it was, we need you to fill out these measurements again and then turn them in. And I went, okay, and did it with the client, put it in the stack of paperwork where the folder was, and then I never saw it again. Can you speak to that, Dr. Klostermann?
Oh my God. That is so common, right? And it sort of leads into the next pieces, which is, how do you integrate the measures or the results of the measures into what you're doing beyond just checking the box, right? So I'm giving these measures now, and then while you're giving them, you're probably thinking, so what am I supposed to do with this, right?
Exactly.
And it ends up in a file somewhere, and then somebody says, okay, now that you're almost done, do it again. And there's probably, even at that point, you're probably thinking, okay, so is there sort of a payoff here? What are we doing? That's such a valid point, right? And it's a common dilemma in terms of, why are we doing this, right? What should we be doing with it? How do we better integrate this into the treatment piece of it? That's why I think it's not just about the measures. It's also about the kinds of conversations that you have about the measures, right? So we, on this date at the baseline, this was the result. Client comes in and fills out the measures again. You look at the score to see what the change looks like. You assess if that's what the client is that accurate to the client's experience, right? What does it mean? If it went up, how did that happen? If it didn't go up, like what's happening now? Or if it went down, then the conversation is maybe, well, so help me understand what happened in the last week. Is it something that we're doing here, or did life happen, right? Like that happens too. People have things that happen from week to week. But I think using the measures over time and having conversations with our clients about what we're tracking and what they're tracking is super important. Having the language even to do that, right? I think that's part of it too, is a lot of times clinicians aren't really sure how to introduce that into the session.
So to that, what was explained to me was that we needed it for a funding source, period. And I also didn't know to ask more, And so then I have the client fill out this information. And let's be honest here, a lot of these measures are tedious, so tedious. Like teensy tiny little text boxes, where you're like checking or trying to type or write something in. And like it's, you're going to get your readers on, and it's coming at you fast with like 50 questions, at least for the ones that I was filling out with clients. And then they disappeared. And I had no idea why we were doing it. And then I remember myself having this epiphany. So in my past life, I worked in medical care and I worked in utilization review, and I was working with insurance companies on getting authorizations and for surgical procedures. And wouldn't you know it, that part of that process was providing some measures to say, here's why this procedure is recommended and justified and medically necessary. And it was like this epiphany years later when I was like, oh my God, that's measurement-based care over there. And we have measurement-based care over here. It was just never explained to me. And hence the conversation we're having today.
Well, and I think that's such an important point, right? Like we never get really trained in these conversations. We sort of figure it out on our own. I remember having the same moment where I was kind of like, well, if somebody was giving me this measure, I would want to know, why am I doing this? Is there any value to it? And then like thinking to myself, well, how could I explain this in such a way that it would make sense, right? Like that people would say, okay, I get why you're asking me to do this. That's fine. I'll do it. So I think like my experience has been clinically, if you provide a context for why you're asking people to do what they're doing, they're usually pretty agreeable to doing it, right? Like in terms of completing measures. Now, the key with the measure, I want to be super clear about, is they have to be feasible, right? Like it can't be giving a 50-item measure on a weekly basis, even a biweekly basis, is a lot, right? So usually the briefer the measure, the better. Now, brief and psychometrically valid. In other words, it has to be a good measure. And there are measures out there that are like that, right? And it doesn't have to be the ORS or the SRS. The PHQ is one that people commonly use. I think that there's different ways of doing this. It's important, though, that it's something that doesn't become cumbersome in the sense of you've got, 250-item measures that you're asking clients to complete each week. I think that's too much for clients, and it's probably too much for the therapist in terms of scoring and interpreting. So that's a really important piece. The measures that you're using have to be brief, they have to be feasible and psychometrically valid.
In thinking back on it, one of the critical missing elements, in addition to what you just said, like explaining it to the client, because I didn't even know it, so I couldn't really explain it. There was just this mountain of data that I was sitting on, and then I completely ignored. Like it was all on this single piece of paper, and then the paper went away. And then thinking back on it, gosh, that could have been really helpful, because maybe I hadn't asked specifically enough about panic attacks, and maybe I hadn't asked enough about trouble sleeping. Tell me more about that. Oh, you're waking up with nightmares, which is different than insomnia and having trouble falling asleep. But like there was all this information, and I really never at that point thought about it as applicable to the work I was doing. And I then came to see it as not only wasteful of the client's time and of the therapeutic time, but that it was actively taking away from the process of therapy instead of adding to it. Can you speak to that? Because I think you're such a wealth of information. And for clinicians listening to this, that are in those environments where everything's coming at you fast. You have more clients on your caseload than you could possibly manage. And then it's like, P.S., we need you to do these measures. And your head is spinning in addition to all the other documentation you already have to do.
Yes, this is such an excellent point. So I think the way you frame it, the way you make sense of it to yourself matters, right? If it's an administrative task that you have to do, that's one thing. But if you see it as, look, this is going to be something that can help me become a better therapist. For me, the way that I sort of make sense of it is, look, I know that like basic outcome data. So I know the modal number of sessions attended is one. I know that the best predictor of outcome we have is the client's perception of the alliance by the end of session 2, not the therapist, the client, right? So I want to make sure that I'm understanding that. I also, based on the outcome literature, I know that probably 20% of clients don't get better, right? Or they drop out before I even know what's going on with them. So I know that there's all of these variables that are sort of client-centric that I can't control. And I see the data as a way of helping me understand and to provide more precise treatment for what the client needs. So it sort of informs my thinking. So I'm thinking the whole time, look, this is going to help me understand so that I don't miss anything. We know that clients oftentimes don't tell us when we're missing things. So I think this is an important piece of it. There's also a self-assessment bias, right? We think we're more effective than what we are. And most of us, when we ask, well, how effective are you with your clients? It's inflated, right? And so it begs the question, well, how do you know? How do you know that what you're doing with your clients really works? How do you know that that's their experience of it? One way of doing this is through the measure. So I think framing it as this helps me to be a better therapist. It helps me better understand what's going on. It helps me retain my clients in treatment longer and also make better recommendations for what their needs are based on what they're telling me, right? So in the way I get all that information, because what you said is really important, Beth. Everything's coming at you really fast, right? But you're going to get information that you might not otherwise ask about. You might not even think to ask about it. Like you mentioned panic attacks, right? Maybe as a result of the instrument that you've given, you say, geez, I've noticed this the last few weeks. I didn't even think to ask about that. And maybe the client didn't bring it up. But this it opens the door for some discussion. Right? I noticed that it feels like seems like this has been a little higher. Can you tell me about that? So I think that's really the value in it. It helps us ensure that we're on track and that we're not missing anything. And that really the true value is we understand when things aren't working before somebody decides to drop out. That's really the benefit of it.
Can you expand a bit more on that research about the frequency of dropouts, about the tendency for therapists to overestimate their effectiveness or the quality of the relationship? I think for me, when I don't remember which, I have to look on my bookcase, which book I had first picked up, or if it was just the research by doctors Barry Duncan and Scott Miller, but going like, oh my God, how is this not taught on day one of therapy school? Can you expand on that?
Yes, and I do think that it might have been in the Heart and Soul of Change, which was a whole collection of different authors that talked exactly about the things that we're talking about. Really, like what works beyond models and techniques and all those things. What are the things that really seem to matter? And not just recently, but since they've been studying psychotherapy research, right? Like this is over time. So I think that it's really important to understand that historically, clients are the ones that are the engine of therapy, and the bulk of what happens in sessions is based on client factors, right? It's not the more specific stuff that we do. It's not the model. It's not the technique. And again, models and techniques are important. They give us a roadmap to follow, right? So it's not, we can't just be atheoretical and go in there. But in terms of what we emphasize, especially in training programs, we don't emphasize the things that really seem to make a difference, right? We emphasize more of the technical at the expense of the general stuff that seems to work across models and techniques. I often say you can be the greatest clinician or greatest technician, right? You can do the model exactly the way that the masters intended it to be done. But if you can't connect with people in a real way, if they don't feel like you get it, right? It's not going to matter. They don't care. The clients don't care about our models. What they care about is that you get it. You understand what they're saying. I found this out in my graduate training. In my graduate assistant role, I had to videotape therapist sessions and then transcribe them. And it was fascinating. Like, it sounds really nerdy to say that, but it was. It was fascinating because there were some people that were just naturally gifted at sort of connecting. And while their adherence to a particular approach might have been a little bit loose, you could tell they were connected, right? There was this latent connection beyond the surface level, niceties that people say. And then there were other people that were really, they asked good questions. You could tell what model they were doing. They were model related, but yet you could tell they were getting a lot of, well, no, not really. Or no. I think, and just as an aside, I think like those yes set responses are a great way for us to understand whether or not we're on track with what our clients are saying, right? If you're getting a lot of yes set answers, it tells us that what the client is saying to you at a latent level is, yeah, you get it, right? That's exactly it, right? Or a client says, yeah, exactly. Yep, that's it, right? Your client's saying we're dancing, right? We're in sync. That's the way I always tell my students. I always think of it as when you watch people who are good dancers dance, they sort of flow, right? Like it's very graceful. When you watch therapists that maybe are struggling, it's really choppy, right? They're stepping on each other. It doesn't feel good. You can just tell, right? When you have that flow, you know it. So I think part of this really is, recognizing that there are let's call them general factors, if you will, like client's perception of the relationship, agreement on the means and methods and the tasks of therapy, right? All of these things matter. Where we get in trouble is when we don't have that, right? That's when our clients don't tell us. They just say, yeah, okay. I can give you a clinical example for myself. So I was I was doing family therapy, and I was in the room, and I had a team behind a one-way mirror, and thought the session was going really well. Everything seemed to line up, like I was working from a solution-focused approach. It was just, I felt like, okay, this is great. Like I'm nailing it. Went back, took a consultation break. The team had really good feedback. Team said, yeah, based on what they said, tell them to go in there and give them a compliment, tell them to do this. I was like, okay, this is great. Feeling really good about myself. Go back in the room, give the compliment, and then I say, yeah, and the team was thinking maybe between now and the next time we meet, you could try this thing. And the family sat there and they sort of did the sideways glances at one another, and they were like, yeah, okay. And I knew something was off. So I said, well, does that make sense? Is that something you'd be willing to do? And they kind of sheepishly said, well, no, not really. That's not what we would do. And it was such a humbling moment and such a great learning experience, because I was like, oh my God, like I really thought that I had nailed it. Like I thought that, and so did the team, right? But it was a lesson for us that we never really know. Like no matter how effective we think we are, no matter how good we think things are going, we don't know, right? And I think we have to have ways of ascertaining what's really happening in the session, right? So routine outcome monitoring, measurement-based care is a way for us to do that. I think of it for myself as a clinician. It helps me to become a better clinician. But I also think there is that piece of, look, for a long time, therapy was this black box, right? And we didn't really know. People would just come in indefinitely, And I think measures are a way for us to also understand when a client has made enough treatment, and that's a collaborative conversation. But when a client has improved enough that maybe it's time to give space out our sessions a little bit more, or it's time to terminate, rather than keeping people indefinite. Part of the challenge now is demand is so great, right? There is so much demand for services. And I think by being more precise in terms of what we're doing, why we're doing it, and also helping clients understand when it's time to transition either to maybe a step down in terms of care, the measures are a way to do that. It helps us understand. I'll just one last comment about that. I think what we find is that when clients plateau at a certain point, they actually will start to regress as they stay in treatment. So I think the measures help us understand where's that sweet spot where clients have made the progress, they feel like they've made enough progress, and now we're ready to maybe step them down or transition them out, with the understanding that maybe we have a booster session or they're always welcome to come back.
Thank you for sharing the analogy about dancing. I was actually going to ask you, what are some things that you consider it analogous with. Coming at this from the medical model, which, I can't really mention without acknowledging extraordinary holes and problems within that system. This is our system in the United States when we're looking at payment by third-party payers, whoever they may be. One of the issues that I see in psychotherapy is its legitimacy. We as clinicians can say, here are all the reasons that this matters and that it's important and that we need to provide these services and provide adequate length of care and all of that. But in the absence of measurement-based care, it's simply one person's opinion. And when we're expanding through the lens of a medical model, granted, let's say you're seeing a rheumatologist, chances are they're referring to some kind of data to determine whether or not you're getting better or worse or staying the same. And that we are part of the billing system. Typically, for many of us providing care, we're operating as licensed professionals, billing with certain codes, using a diagnostic code, all of that. And again, I'm not necessarily singing the praises of the system. I'm just existing within the system as it is. And within that, we need to have our own version of legitimacy then to be able to say, this is not just my opinion, because as you said, turns out we're not very good at it. We're not very good at the assessment. We're like, I think they're getting better. And then you ask the client, it's like, I'm getting worse. Or it's like, I think we have a great relationship. And the client's like, she doesn't listen to me and she talks over me or whatever it is. And so then it's like, okay, we have a fundamental problem here. And how are we going to make informed decisions that we can actually hang our hat on instead of kind of these arbitrary things, especially if we're being caught up in the medical model? That it's like, again, my early days in any kind of medical or mental health care, starting in medical and realizing it all came down to the measures. It all came down to the measures. What popped up in the blood work? What was the measurable impact of some intervention? And if there wasn't a measurable impact that was positive, then we should probably be looking at a different intervention. And that's a whole different paradigm than many of us really view therapy through.
Well, and I think this is such an excellent point. We're just not trained that way, right? We're not trained to think that way. And I completely agree I appreciate what you said about the medical model, and everyone has their thoughts about it. It's the system that we're in. That's the reality of it, right? And we have to function in an effective way within that system. And I think, some of it really is, why not? Why wouldn't we want to know if things are working or not working, right? It's not about us. It's about our clients and whether or not they're getting better. And I think that's the piece where it's like, look, the measures aren't necessarily our enemy, or the results. They could be friendly to us in terms of us growing as clinicians. I'm sure therapists this way, where it's like, look, when the client gets better, we're the hero of the story. Right. And when the client doesn't get better, it's because she or he was resistant. Right.
Yeah,
it's
totally.
the client. Yes. And I think, the question really is, when it's not working, how come? And it doesn't mean you're a bad therapist. And I think that's the message that's sometimes internalized, right? The reality is, I mentioned earlier, we all go into sessions wanting the best for our clients. We want them to have the optimal experience, right? We want it to be a home run. The reality is, change is incremental and it's slow. We often don't see it right away. There's not a ton of instant gratification in really significant ways. That's why when we have those moments, those breakthroughs, it's like, oh my God, this is amazing, right? This is why I'm in this field. This is what it's all about. So I think part of it is recognizing the realities of what we know about the process and using the tools that are available to us, rather than getting into this sort of, this paradigm battle about whether or not we need to use measures. The measures are taking away from the real stuff that happens in sessions. I would argue that the measures are a really important piece of understanding how to do the real stuff, if you will, because otherwise you don't know. Like you said, Beth, we're relying on what we think, which may or may not be biased. Accurate. Right. Exactly. Right. We all think we're great.
I think that part about relying on measures, I think for many, we're deep feelers, by nature of therapists. We tend to be deep feelers, deep thinkers. We connect with our hearts. And I think it can feel cold and impersonal. I would love for you to expand on your positioning with clients, how you sell this concept, and then how you integrate. And again, like Keith and I are both trained in feedback informed treatment. So, of course, we're going to look at measures we're very familiar with. I've used so many measures, so many acronyms. So, really, this is talking about any of those measures. But the integration, tell us how you do that and how you keep that warmth and also use it to guide treatment and really sounds like a poor word choice on my part, but how you like sell this concept to your clients so that they understand this is why we're doing this.
Yes, this is where the rubber meets the road, because the measures, like I said earlier, the measures are great, but they're not a panacea. By themselves, it's just a number. If you don't understand what that number means, right? If you don't have a context for that, then you have nothing. So I guess I would say for me, and before I even get into this, I think that the measurement-based care piece is pan-theoretical. And what I mean by that is you can apply it to any approach you're using, right? All it is it's another piece of information that's helping you understand what's happening. So depending on what you want to assess, again, you choose measures that are feasible, that are psychometrically valid, and make sense, right? You don't want to give a measure that's 50 items each week. The fatigue and burnout piece of that for the clients and the therapist is going to be too much. But what I do is when I introduce myself, when I start therapy, I think of myself as being a good host, right? So I introduce myself, I talk about how I work, and part of that is saying, each time you come in, I've got these measures I'm going to ask you to complete. And here's why we're doing this. One of them looks at this, right? And it helps me understand whether or not we're on the right track. And I'd ask that I want you to be honest with me, because it helps me then better understand what we might need to change. So I think honesty is key. I joke with my clients, I make mistakes all the time. It's one of the things I'm really good at. So if you're not getting what you need, if things aren't improving, I want you to make sure that you record that, right? That's captured, or you tell me. So I give them permission to give me feedback in a way that they're experiencing. And I continuously reinforce that, and I invite questions. So I think part of it is being transparent with the clients about how you work and why you're doing it. I mentioned earlier, my experience with clients is if you explain it to them, if you explain why you're doing what you're doing, most of them don't have a problem with it. They may say, well, tell me more about that or help me understand. And I will. There's no mysteries, right? I think part of a lot of what we do early on is demystify the process, because so many people come into therapy without really understanding what it's about. And maybe their only conceptualization of what it looks like is what they've seen on TV or what other people have told them, which may not have been a good experience. So I think part of it is saying, this is what you can expect from me, right? Every time you come in, this is what we're going to do. And having conversations. So then it becomes part of our routine. It's baked into everything that we do. It's not just this, oh, by the way, we have to do this. Or it's not, I'm doing this because I have to do this, right? I'm doing it because it helps me better understand what's happening for you. And with the goal that we get you what you need.
For me, I think that's been one of the most enlightening parts of measurement-based care, and not just in my own work, but also in the work of the clinicians that I've worked with over the years. For me, I've come to have a different relationship to not only therapy, but actually like just all interactions of like, basically, does what just happened between us, did it leave us feeling closer together, exactly the same, or further apart? Like, where are you at? And I think it gave me more confidence to exist in a space where that was separate from me. That was something that I could learn about and that I could work on, and have some level of neutral-ish curiosity about, that I'm like doing some intervention and my client is internally like rolling their eyes being like, cool, there just went 16 minutes of my life that I paid for and I can't get back, not the money nor the time. And that out of respect, they might never say to me like, that was stupid. Like, I don't like the whiteboard thing, or like that, like, closing my eyes and visualizing success or whatever it was that I did, that they were just like, why am I here? To exist in a space where I say, hey, this thing we just did, what was that like for you? Can you tell me more about that? Do you think that worked? Do you think that was good for you? Or even better, in what ways was that good for you, or did it not work, to open it up to really hearing that feedback. And it's a whole different perspective where we're really, oh no, I'm warning you, Keith, Beth is about to Beth right now, where we're tearing down the origins of early therapy, and it stops being about therapist as expert and it's actually about client as expert. I would love to hear kind of your perspective on that. And these are my musings, in between sessions that I'm sitting here going, in the art of therapy.
Well, I think this is such a really critical piece to this. Like sometimes we get so wrapped up in the things we think we're supposed to do rather than privileging the client's story and understanding what it is that they need. I think we can sometimes get enamored with certain parts of our models or our theories that lead us down a rabbit hole that may not be consistent with what it is the person actually came in for. So I think having a humility about what is my role in this, and even finding out from clients, right? Like, what are your goals for the process? How can I best help you in this, right? What's my role in this? I sometimes think of the relationship between myself and my client as, well, what are we going to be about? Right? What is my part of this? What's my piece of this? It doesn't matter. At the end of the day, honestly, I always think it doesn't matter what I think, right? Like the client's experience is unique so how can I best help that person? I may not necessarily agree with it or understand it, but who am I to say? Who am I to judge? I think you have to have a willingness to take the expert hat off and to really just seek to understand, right? What is this? What does this person need? What does this person want? Am I capable of being that or doing that? If not, then we have a conversation about it. Clarifying what's the client's goals? What's the intent of some of the behavior? I think so much of what we do in therapy a lot of times is creating awareness, helping people to maybe see things in a way that they just can't see. By the time they come in to see us, they're almost laser focused on a particular issue or circumstance. A lot of times what we're doing is expanding the perception again to see, are there other options? Are there other ways of doing this besides what's currently happening now? And maybe at times really what we're helping people to do is to, speak the unspoken things out loud, right? The things that people have sort of known intuitively but have never really said. And that's part of what we do. But I think it requires us to get out of our own way sometimes and to allow our clients to lead and to be comfortable with that. I've never been a person that's felt comfortable being the expert on anybody's life. I'm trying to figure out my own life, let alone tell somebody else how to live theirs. I mean, that's the way I really look at it, and I respect the fact that for me to tell somebody what they need to do or what they should do, they've had tons of people do that by the time they walk into my office. And guess what? It hasn't worked. So me being the one person that doesn't do that maybe helps get the buy-in, right? And also we have a different kind of conversation then. And that's why I think that's where the measures come in handy in terms of making sure that what we're doing is actually moving the needle in the right direction. And if it isn't, and again, I think this is really the most important part of using measures. If it isn't, I know that it isn't. And we can have a conversation about doing things different rather than doing more of the same.
That, I think, is one of the biggest dangers. So, the research about somebody dropping out of therapy because they felt like it wasn't working. And then the research has shown that they're much less likely to ever pursue therapy with anybody else ever again. So that's terrifying. So it's not just with you, it's the whole institution. It's we don't want to do that. And then also, if we don't give them, if not we, but if the work doesn't give them some direction and sense of accomplishment within a certain number of sessions, and it's not that many, then they're less likely to ever really achieve what they came in for. And thinking for myself, working and having 2 dogs, including an insane little wonderful puppy, and 2 kids, and all of these appointments all the time to get the teeth cleaned and to get the nails cut of the dog, or all these different appointments. And if I feel like any of those appointments aren't working, then I'm just going to not go, right? I don't have time for that. I don't have money for that. And so you can understand how a client would just be I'm just not going to rebook next time. This isn't working. I'm just not going to go back. And I tried therapy. It didn't help me with XYZ. So I'll talk to my doctor about, upping my dose of medication or whatever it is. And I don't think it's hard for us to see how any of us could get there, but how different it could be if we created an environment where we're actively seeking feedback and then actually using it. And I feel like that's the part that here I was actively seeking feedback, at least via some measure, but I certainly wasn't using it. And then it's just lost.
Yep. That's the biggest challenge that I've seen, Beth, like even in my role at CVN at the Cohen Veterans Network. So we help clinics to use and implement measurement-based care. And one of the challenges is that therapists will often administer the measures, but they don't incorporate it into the conversation or the discussion. So it's like you look at a note, and the note has the date and it has the assessment results, but there's no discussion of how that was used. So it's like, yeah, we did it, but you're missing. This is like you got it half right, right? Like you took the time to do it. Why not incorporate it? Take that next step and incorporate it into what you're doing. And I think that's sometimes the challenge is, what is the language that you use? How do you introduce it? How do you explain it in a simple way that makes sense, right? That makes sense to you as a therapist and also to your clients. When I first started doing this, I scripted out what I was going to say because I would sort of practice to myself, and I found myself getting all jumbled up and tripping over myself. And I thought, well, you know what? I'm just going to write it down. And then I became more, I refined it and became more comfortable with the words and the language, and also more comfortable with what it was I was trying to do. At its core, I'm trying to provide a better experience. The measures are a way of doing it. It's not the be all end all, and I'm very clear about that. It's not all about the measures, but it helps us in the work that we're doing, and that's why we're doing it. And if at some point it wouldn't be helpful, I wouldn't do it. So I think I think if you can come to it, if a clinician can come to it from a place of understanding, this is why I'm doing it. This is the hook for me. I think it's going to help me to better meet your needs. It's going to help you to understand where things are at. Having a quantifiable data point is often a lot easier for clients to sort of hang their hat on, as opposed to, well, how are you feeling this week? Well, better, right? But what does that mean? What does that look like? So I think that the measures can be a way, the results of the measures can be a way for us to do that and to better understand.
You've already given a couple of examples, and even just the way that you're presenting the information, I think, is informative for listeners. I'm just curious, has it ever happened that a client says no?
Oh, yeah.
So tell us about that. Because I want to talk about that part of it too, because it's like, we're like, no, if you just sell it right, like this, you can cook a rotisserie chicken in 13 minutes, like whatever it is, like if you just position this product correctly, they'll buy. What about when they don't buy? And then like, what do we do?
Yes. So in those cases, I think the measures are a tool and they're an important tool, but I don't really, if somebody says to me, I'd rather not do them, we'll talk about it. And then I say, okay, it's not about me. It's not about the measures. It's about them. Again, I'm thinking strategically, because if a client's telling me, I don't want to do that, and then I say, well, I want you to do it anyway. Now I've got a mismatch, right? And I'm going to damage the alliance. And if client says, I don't want to do it, I say, you know what? I totally get that. That's fine. I might revisit it at another time if I feel like there would be value, and better, like maybe understanding what's happening between us. But I'm not going to get into a power struggle with the client at all. And truly, like if I'm asking somebody if they're willing to do it, that's their right. If they say, I don't want to do it, I say, okay, that works for me. I think honestly, I think the selling is just, I don't even think of it as selling. I think it's just about being transparent and honest about what's the purpose of doing it. My goal isn't to trick anybody. It's not to get anybody to do anything they don't want to do. I just see it as something that would help us. But if somebody says to me, no, you know what, I don't want to do that, I totally get that. That's fine. You don't have to.
I love the mindfulness there about power. I think is really what we're talking about, like kind of power over right there. If it's like, well, you need to, and then trying to sell them on it. I would love for you to finish the sentence as if you were talking to a client and you just started to say it, but I want you to finish it out. My goal is.
Oh, my goal is for you to have a good experience and for you to get everything out of this process that you're hoping to get, and to help you in that, right? That's really, for me, that's what it's about every time somebody comes in. And that's why I think, like, and I've always felt this way. I'm not going to be everybody's cup of tea as far as the therapy goes. And it's true for all of us. So if it's not working, if it's not clicking, it's okay, right? I would rather refer that person or have a conversation about what else might be helpful rather than sort of hanging on to a client because of my own ego and my own insecurities, right? I'm going to make this work no matter what, even though it's not working. It's like, what are we doing? Who is this about? It's not about me, right? It's about helping people get what it is that they're looking for, what they came in for. If I can do that, that's wonderful, right? It makes me happy too. If I can't, that's okay too. And I also know that it doesn't mean I'm an awful therapist, right? It just means it wasn't working, and that's okay.
I think that what you just said is so powerful and I think really difficult, especially for new therapists, like my past self included. One thing I came to appreciate is that, like, I look at it like therapists are flavors of ice cream. And like, you don't need to tell me why you don't like it. It's okay that you just don't like it. Like somebody else, like, I do not understand Cherry Garcia. I just don't. There's not, I just sometimes I can't explain it. I just know I don't like it, but give me a mint chip and we're good. It's not working. But also, like, to get away from like a food analogy, if we're interior designers and like our specialization is like different shades of, bright pink and like integration of like a lot of like geometrics, and the person's like, I prefer neutrals, where it's like, that's really okay. Like, I'm just not your brand of designer. That's totally okay. But it also, it takes a lot of ego strength, and it takes a lot of our trust in the process to be able to not make it about us. And we're going to, I think, inevitably, like, we have our moments, we're human, but to let the client experience really be the most important aspect.
Yes, I completely agree. And I think you have to be willing and ready for somebody to say, no, I don't want to do it, or no, this isn't helpful, right? If you fall apart when somebody says that, like, well, you probably, you got to work on that then, right? I can remember like teaching therapists to always ask about what at the end of each session, was this helpful today? What was helpful about it, right? And there were some therapists that would, like, you could tell they were cringing before they said it, right? It was like, was this helpful? Like, sort of bracing for impact, even though, like, what are we talking about here, right? Like, it should be helpful. If it's not, shouldn't we want to know that? Or should we just go on and in ignorance, and pretend it's fine? Like, I think that's where it's like you have to sort of really reflect on what it is you're doing and why you're doing it and who it's about. I mean, that's really important. I also think that part of it, it's incumbent upon us to create a climate where clients can feel safe to say what's happening for them, right? Like, if they're not having a good experience, it's okay to say that. You're not going to, I tell my clients this explicitly, you're not going to hurt my feelings, right? If you feel like we're talking about, or we should be talking about something else, it's totally okay to say that. I want to know, right? Because I miss things, and sometimes maybe I'm missing something, and that's okay to say that, So I think, like, it's incumbent upon us to do that. And also, I think we have to recognize that when clients do it, it takes a lot of courage to do that for some clients, right? Like, because many of them are like, well, he seems like a nice guy, I don't want to hurt his feelings, or I think there's that piece of it too, where we have to recognize and honor that. Like, somebody like was willing to do that. Like, that's really cool.
Yeah. Yeah, absolutely. And just let the record show, I was absolutely one of those therapists that it was like, so how is my session for you? Like, all of a sudden, like, my posture changed, my voice got really tiny and high pitched, and wanting to do it well, being afraid that I'm going to get feedback that's saying I didn't. And then what do I do with that feedback? And that for me, was like development of self as therapist, but also like development of self as human. It turns out that when I was doing that in my early days, my frontal lobe wasn't fully developed. So just throwing it out there. There's that. There's that. But yeah, it is. It's a pretty extraordinary thing when clinicians are able to put themselves out there openly, and then when clients are able to put themselves out there. Because, like, how many times have we been somewhere where someone asks for feedback in whatever way, and we're like, yeah, no, it's totally good, it's a great movie, and then you're walking out being like, oh my god, that was the worst. And that it's only if we have some kind of skin in the game with that person and relationship to actually be like, oh, I'm gonna be honest with you here. I kind of felt like that one scene was really drawn out, and I thought the audio was kind of the dialogue was kind of difficult. So it's like, that's feedback that would be really valuable for the filmmaker, but I don't think the filmmaker's getting the feedback. so I appreciate the idea of kind of really both sides are acts of, I guess, almost acts of bravery and acts of trust, to be able to withstand things not being perfect and then work through it together is really a beautiful thing. I, of course, just want to keep talking, but then I'm looking at the clock going, okay, we've used up our time. Keith, I'm sure you have more to say on this topic than we talked about today. And you've already given some great resources, and I encourage our listeners, go take a listen to some of the other episodes with Dr. Miller, with Dr. Chow, and think about these concepts. Check out the blogs that Dr. Klostermann had mentioned. Keith, what are other resources that you found the most helpful in your development and eventual embracing of measurement-based care?
I think that the two primarily are the International Center, as we talked about. Daryl's stuff is really good. And then the VA has a whole manual. The VA healthcare system has a manual on measurement-based care that is I believe it's publicly available. That's been really helpful. The VA has been at this for a while, trying to crack this nut of implementing measurement-based care. So I think they can be a good resource. I would also check out the Cohen Veterans Network website. So we really have, to my knowledge, we're the first group that has really been able to partner with clinics to implement measurement-based care in a sustainable way and also in a clinically significant way. And what I mean by that is beyond just getting people to do the measures, but making sure that they're incorporated into treatment. And then having part of what I do in my role as quality assurance manager is ensuring that the clinics really are doing it. We do that through chart reviews, conversations with clinicians, with clinic directors. So it really is there's a lot of really cool stuff happening in terms of measurement-based care and CVN.
Super cool. And Keith, for people who want to learn more about you and your work, what's the best way to do that?
Either on the Cohen Veterans Network website or at the Walden University website. And I'm also on LinkedIn.
Awesome. Thank you for joining us. I think these concepts can feel really foreign because they, for many of us, were not introduced early. And maybe we're 30 years into our careers and hearing this conversation and being like, hold on, this is a whole different way of operating. I appreciate you coming on. Go ahead.
No, I was just going to say, I think that's a really important piece too. And I don't want to minimize that. I think it's hard, right? If change is hard for all of us. And if you've been doing things a certain way for a long period of time, and now all of a sudden somebody comes in and says, you have to do it this way. And if there isn't a really clear explanation of, well, why are we doing it this way or how do we do it this way, I think it's tricky. And it's part of the reason why measurement-based care hasn't been as widely adopted overall as it could be. I think that we have to really rethink about how we teach people and how we train people to do measurement-based care and when's the appropriate time in someone's career. And I think some of it depends on the clinician too, right? We all know clinicians that have been in the field for a long time that just sort of do the same thing over and over again, right? And it's oftentimes we make the mistake of equating effectiveness with experience, right? This person's been in the field for 25 years, they must be good, but there's no willingness to self-reflect or to change and grow personally and professionally as the field evolves. So I think that I don't want to minimize. I think it's hard for clinicians that have been out there for a while practicing to shift. But if you can shift in a way where you feel that it's going to help you grow as a clinician, right? It's going to make you better. It's going to make you more effective. If you can see it that way, sometimes it's a little bit easier.
Totally. It was so nice to have you again. Again, for our listeners, Dr. Keith Klostermann, please check out his work. And like I said, check out the work of Dr. Scott Miller and Daryl Chow. Thank you so much for joining us again, Keith. It's wonderful to have you.
Thanks, Beth. This is great. I really enjoyed it.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need Continuing Ed credits, please visit us at clearlyclinical.com to check out our one-year membership, where you'll have access to our growing library of Continuing Ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.